And we're going to move on now to Sarah Pirio Richardson, and she's going to talk about strategies for add-on therapies for individuals using botulinum, looking at the yo-yo effect. Let's play from Sarah, please.
Good afternoon. I'm very happy to talk to you today about strategies for add-on therapies for individuals using botulinum neurotoxin. I'm going to share my screen. So I'm Sarah Pirio Richardson. I'm a movement disorder specialist at the University of New Mexico, and I'm also at the New Mexico VA healthcare system. So my agenda for this very brief talk is first to describe the challenges of the botulinum neurotoxin treatment cycle and how that impacts on potential trial design for add-on therapies. I'd like to take then some time to go over two trial designs, one of which is about the timing of the intervention in the botulinum neurotoxin cycle, and that's some work I did some years ago. Maybe talk a little bit about the pros and cons of that approach. And then I'd also like to review a study that really used the characteristics of the botulinum neurotoxin treatment cycle to enrich their study population. So we'll go over that as well. So what are the challenges in a botulinum neurotoxin treatment cycle? And I think many people know this already. There is what we hope to be the typical or the ideal treatment cycle where a participant is injected in at their scheduled botulinum neurotoxin appointment. Then there's a gain of efficacy, an improvement in their symptoms with a peak effect somewhere between 4 and 8 weeks, around 6-week mark. And then from that point, there's a gradual resumption of symptoms returning, hopefully not all the way back to their previous baseline, but to a nadir around the 3-month time period where they would have their subsequent botulinum toxin injection, with the idea that they'd reach the same efficacy over and over as they go through this treatment cycle. So even with a typical treatment cycle, and we'll talk at the end about some atypical treatment cycles, there's still the question of when and where you should be doing these potential add-on therapies. So one approach would be to do it at the peak of the effect so that you may increase the efficacy as true add-on therapy with botulinum neurotoxin. Another possibility would be to try to address this wane of a treatment effect and see if you could either intervene to improve or change the slope of the loss of efficacy over time. And then the third possibility is, can you do something to the overall baseline to keep it up above a certain marker of efficacy so that people have a more consistent therapeutic effect, even in a cyclical treatment like this? The challenges are that there are concerns at each of these time points. So the first one would be, if you're adding on a therapy at the botulinum neurotoxin peak effect, you may mask additional benefit, and there could be a ceiling effect of our current outcome measures. If you're looking at the wane of the treatment effect, it's possible that other things aside from just motor symptoms may play a role. There are negative motor, pain, and psychosocial effects at the end of a cycle that may blunt add-on benefit, and we may not see that and give up on a potential add-on agent that was actually effective, but because of these other factors, that effect was blunted. And then finally, in considering how to change the overall baseline, it's really going to require multiple evaluations over many treatment cycles to deal with inherent variability. I've showed you a very nice graph where the effect reached with every botulinum neurotoxin treatment is the same, but that may not be the case, and there may be more variability that may again mask improvement in the overall baseline based on an add-on therapy. So I think these are, in general, the main concerns that we have to deal with when planning or designing an add-on trial for botulinum neurotoxin therapy. So let me give you 2 examples, and then happy to answer questions and maybe discuss this a bit. The first is an example of a trial that I did quite a while ago at the wane of the therapeutic effect. So this was a repetitive transcranial magnetic stimulation in cervical dystonia study where we looked at the effect of site of stimulation and repetition in a randomized pilot trial. I did this with my colleagues Shuli Tanaz and Robert Chen, and it was supported through a Dystonia Coalition Career Development Award and through funding through the DMRL, the Dystonia Medical Research Foundation. So we took the approach of looking to see if we could plan our intervention at the 2-month mark. So after the effect of the previous toxin cycle was starting to wane, could we add on a therapy at that time to alter the trajectory of the therapeutic effect of botulinum neurotoxin? So a very small trial. We had 8 individuals with cervical dystonia. You can see the age range was from early 30s all the way up to 72. We had almost even males and females, and their disease duration ranged from several years to up to 22 decades. Their severity scores you see ranged from kind of moderate to more severe cervical dystonia, and also had, again, a range in terms of pain and disability related to their cervical dystonia. And so with this small trial, we did a crossover design in order to use patients as controls against themselves. So we could look at some of the effect of site of stimulation between subjects in this crossover design. So here's an example of where we did our stimulation. So people were randomized to a therapeutic intervention of repetitive transcranial magnetic stimulation over 5 possible sites. The green marks the primary motor cortex over the hotspot for the hand. The blue is the dorsal premotor cortex. The orange is the supplementary motor area, and the pink represents the anterior cingulate. In addition, we had a sham condition over the dorsal premotor cortex. So same location, but it was a sham stimulation. So they were randomized, had a random order, but crossed over to each of these 5 stimulation sites, beginning at 2 months after their previous botulinum toxin injection cycle had begun. We assessed patients pre and post stimulation via video that was then rated by a blinded rater for the clinical severity of their torticollis. And we had at least 2 days in between each of the stimulation settings. So this occurred from, let's say, month 2 to month 3 post botulinum neurotoxin injection. And I'll just briefly go through the results because I think when you are doing an add-on therapy at the wane of therapeutic benefit, the question of what you compare your results to or what is the appropriate outcome measure to be looking at is not trivial. So the first data that I'm going to show you is the change in the Twister score by site. And what you see is along the y-axis, we have change in Twister score. If you were going into the negative, that means there was a decrease in the Twister score, again, by a blinded rater, and so improvement in their cervical dystonia symptoms. And this was pre and post, right after that site had been stimulated, right before and right after. And you see there was improvement over the dorsal premotor cortex, over the motor cortex, perhaps a little over the SMA. Sham didn't show really any change, and the anterior cingulate, if anything, showed a little worsening, but overall no change. So this is the immediate pre and post. But interestingly, if you look at change over time, we found some interesting things, and this also brings up the issue of what do you compare that change to. So again, the Twister severity score is along the y-axis, and you can see the mean Twister severity. And then along the x-axis are the session times. And these, again, ranging from session 1, which was after the 2-month mark, after the botulinum neurotoxin injection, all the way to the 3-month mark, which would be subsequent to treatment number 5. So plotted all the individual subjects along here, as well as their mean data, which is this blue line here. But I think what is interesting, so if you look at the blue line, what you see is a decrease in twister severity over the whole group over time. But the question is, what does that mean? And one of the ways to interpret this is to compare this to the natural history data of what we know happens between about month 2 with the wane back to closer to their baseline. And that's marked here in the red line, where you can see we use data from a large botulinum neurotoxin pivotal phase 3 trial, and looked at their twisters mean scores at month 2 to month 3. And what you see, and which is not unexpected, is that there's a slight worsening in that twister score over the time as the effect of the botulinum neurotoxin wanes. And this then shows a difference between what happened to our group with this add-on therapy during that waning period, where instead of worsening, they actually had improvement over that time period. So wanted to bring this up as one strategy to evaluate a add-on therapy in a botulinum while allowing people to continue in their normal botulinum toxin therapeutic cycle. I want to turn next to another approach, which is about timing, when you time the intervention, but it was also about enriching your patient population. So this was a randomized study of botulinum toxin versus botulinum toxin plus physical therapy for the treatment of cervical dystonia, which came from Dr. Wagle-Schukla's group. What you see here is some atypical, or maybe not the typical or ideal botulinum toxin cycle, where instead of getting a full effect or the wane lasting out to 3 months, you actually get a short duration of therapy with wearing off of the toxin effect back to baseline before the next injection cycle. The other thing you can see here is another potential way that someone would respond to botulinum toxin, with a potential decrementing effect where they're at each toxin cycle, they have less and less benefit over time. And Dr. Wagle-Schukla's group took advantage of this and actually planned their study around cervical dystonia patients who were receiving botulinum neurotoxin every 3 months with a less than 30% response. So folks who were not responding as well as one would like to the therapy, and so they would potentially be eligible for some kind of add-on therapy to toxin to improve their symptoms. That does 2 things. One, it probably prevents some ceiling effect by choosing this patient population, but so that you can actually judge add-on therapy. The other thing that they did was look at looking at benefit that only lasted 8 to 9 weeks. So people with a short duration therapeutic response. This is their demographics table, just to show you the patients were in their mid-60s. They had been getting toxin therapy for almost a decade with doses in the mid-200s. Their benefit was around this 8 to 9 week time period, and had severity on the totals, the twister severity score of 18 to 22. There's also some things down here about some neurophysiologic parameters that she looked at as well. I'm not going to show you that data. So it was randomized in a block design, a group of 4, where you had a botulinum injection alone arm, there were 8 in that, and botulinum injection plus PT arm, there were 8 in that arm. So they did EMG guided Botox in both arms, but then in the PT arm, they did a post-injection 60-minute deep massage and myofascial elongation, and then trained the participants for an at-home exercise program. They were instructed to do this program 15 minutes for 5 days per week, keep an exercise log, and do this for 6 weeks. The group then returned at their peak effect, and this is what the final data showed. So along the y-axis is percent change at peak visit, and the dark bars here represent the physical therapy plus botulinum toxin group, and the gray bars are the botulinum toxin group alone. And what they were able to show was significant improvement in pain scores, in severity scores, range of motion, and another range of motion in lateral flexion to the right in patients who had the botulinum toxin plus physical therapy arm. They, however, were not able to show a prolongation of the duration of the botulinum toxin effect, so still stayed around the 8 to 9 week time period. And again, their intervention was for the first 6 weeks of the cycle. So I'm going to conclude with those, going over those 2 brief studies, just to bring some attention to the question of when you time your study, and some ways to get around some of the concerns, such as ceiling effect, by choosing a patient population that maybe has a lower beneficial effect to toxin might eliminate that ceiling effect, or considering targeting those folks with a short duration of therapy, or targeting that weighing over the last month of therapy for evaluation of potential add-on therapy. Thanks for your attention. Very happy to talk and answer any questions if there are any. Thanks very much.
Sarah, thank you very much. That was a terrific talk. And I'm looking to see if there's any questions in the chat or the Q&A. And while we're waiting for those, I'm going to throw one out there, of course. Sarah, I thought you brought up a terrific point that I'd like you to expand upon a bit. And that is, in the varying times of the cycle, there may be substantial variation in the non-motor components that's contributing to the disability from these people. And so how do you deal with that in assessing where you're going to go, and how do you assess intervention? And I could have seen, like you had in your first example, there's this one person who was really much worse. And I wonder if that person was much worse because of the non-motor aspects, as opposed to just getting injections or something, or the TMS in the wrong spot. So how do you deal with this?
Yeah, well, perfect, Joel. My strategy worked. I was supposed to talk a little bit about our patient-centered outcome, but I was hoping to set the stage of why I think it's so important that we have this tool. Our patient-centered outcome is specifically going to measure aspects of response to motor symptoms, ability or disability symptoms, as well as psychosocial aspects, including quality of life and pain and other features that might be at their peak when the symptomatic benefit of toxin is decreased. And I think we need to have those assessments that can look at all of those aspects all the way across the toxin cycle so that we can analyze it correctly. I think it's entirely possible that our treatments can't solve every problem that patients are having, that we have, directed therapy for particular symptoms, but we may be discounting a therapy if we don't understand how it is, how patients are responding or analyzing the response to the treatment effect, if we don't really capture the full picture from the patient's point of view. Yeah, thanks.
So this is a challenge. So how do you put what's the gold standard? Is the gold standard the patient's report of the outcome, and then you look at a hierarchical progression of your different components and see which best explains that? Because after all, Eugene Stead, who is a famous internist many, many years ago, said, ask the patient, they'll tell you
right.
What's wrong with them.
Right. Yeah, no, I think it's a huge challenge. And in my interactions with the FDA and the development of this patient-centered outcome, those have been some of the questions they pose, is that you have to be flexible in how you use the tool and how you interpret the tool. One of the goals that we have moving forward in this PCO project is to be able to compare and contrast patient report of their symptom benefit or symptom non-response with Dave's approach of an objective measure of clinician rated measures. I think you really do want the 365 view to see where there's potential gaps and where what we think we're treating is not where the patient is. So I think, that was something that the FDA really tasked us with in terms of thinking about the development of this measure, is that we really want to capture things that are meaningful to patients, but recognizing that across those multiple domains, some of those responses or their experience should be taken into account and interpreted, but these other measures are also important in assessing therapeutic benefit. So I think it's very complicated. I don't think there's a very clear, straight answer. I think we're going to have lots of information, which I hope will enrich our view of this. But it is complicated to sort through each of those issues.
Thank you. Tony Lang put a question in the chat. I'll read that. An effective chronic therapy should probably improve both peak effect as well as sustaining the effect, i.e. improving the trough. In a within patient evaluation, how many control cycles of botulinum response would need to be evaluated to compare to the experimental treatment to account for the variable responses? This is where objective measures would be very helpful. Go for it, Sarah.
Yeah, well, I couldn't agree more. I don't think we know how many control cycles that we would need in our PCO project. We went with 3 cycles to get over a 9-month time period. And I think that will give us some idea of the effect size over time within an individual as well as within our group. So I think we'll be a little bit closer to the answer of how many cycles you really need to know in terms of understanding the variability and to be able to calculate an effect size. Because we are pairing our study with objective measures, I think that's gonna make the data even more robust in terms of effect size seen from a patient perspective, from a clinician perspective, as well as from an objective perspective that might help us plan our future interventions. Because as you said, that's what we want to do, is we want to make a sustained chronic therapy that minimizes any of the trough effect and maximizes the peak effect for patients over time.
And that's going to depend upon your non-motor variability as well as your motor variability. You just make it complicated, don't you? Other questions? So how do you know 3 cycles is enough? What's your metric for that?
We don't have a metric for that. I think it fit very well into the trial design in our grant application. I think this is the challenge of funding cycles and trying to figure out what's pragmatic and feasible. This is a patient population that is coming in chronically for therapy. So I think that does open the ability to watch people over a longer period of time. I don't know that our funders are excited for us to do that over a very long period of time. And so I think we were being pragmatic and trying to, I think all of us have had that experience of a patient who's responded very well for a long period of time. They get diagnosed with an intercurrent illness or have something very stressful go on in their life and have a dose that does not seem to kick in. They really have a loss of effect. And then after those things settle down, the subsequent injections are going well. So we didn't want to do 2 cycles or even 1 cycle, but 3 seemed to make sense. But that may not be the right number either.
Pragmatic reasons. Those are always important too. Other questions? Well, we're almost to the point where we're ready to go for the general question and answer session for the day. Why don't we turn to that and open it up for any other questions that others may have, or residual questions from any of the speakers, or just discussion points. I'm feeling like the Muscular Dystrophy Association telethon. I'm waiting for those phones to light up. So these objective measures and all of these issues with the variability can be very critical for us to assess efficacy of new therapies. Marie, did you have a comment? Marie's comment is, this was very clear. Thanks a lot for all speakers and Q&A discussion. Thank you, Marie, for those kind words. Oh, and Tony Lang makes, you always remind me of Jerry Lewis, Joel. Thank you, Tony, for that comment.